So thank you for joining me again with this series of study with me. So I'll try to do the same lecture in Arabic as well as in English as per your request. I'm hoping you find it useful for studying and for the exam. So in this lecture we're talking about the oral cavity, and as we all know that oral cavity tumor will include lip, anterior tongue, floor of mouth, blah blah blah, and retromolar trigone. And retromolar trigone, some would consider it part of the oropharynx, and some centers they treat it as if it is an oropharynx because sometimes surgery is difficult to treat. But embryologically, I think the retromolar trigone is part of the oral cavity. So if your surgeon are happy to operate, let's operate on it, and then the patient will come to have adjuvant radiotherapy afterwards, or adjuvant chemotherapy and radiotherapy together. Let's start by the lip, and the lip is or usually we look at it as part of the skin, because the technique of radiotherapy is very close to skin cancer, and the lip also is very common in the exam, I have to say. So if we look carefully on the lip and start to do it, you may master your skin radiotherapy as well, just by starting your by doing the lip and mastering the radiotherapy technique for the lip. Before we go for the technique, I want you to understand a few points. I think the anatomy is very important. So when we talk about an oral commissure, you should be aware where is the oral commissure. If you are talking about the upper lip vermilion and lower lip vermilion as where the tumor usually arises, you should know where is the vermilion. Otherwise, it will not be clear for you. The oral commissure tumor is a common site, or it's common for the oral commissure tumor to come to your side, as the surgeon usually may come and say that patient may suffer from drooling after removing the tumor because of injury of the orbicularis oris muscle, and he would prefer you to treat with radiotherapy. So it comes a lot. The oral commissure lower lip tumor has nothing to do with the smoking of the pipe. So this was very common in the old days to say that pipe can predispose to lip cancer, but it's not very, I don't think it's proved to be. 90% of the patient will come with lesions in the lower lip, and very few will come with lesion on the upper lip. And the majority of the upper lip tumor will come at the nostril side, going down to the lip, because so it's not common to see an upper lip tumor, and most likely that the exam will come with a lesion in the lower lip tumor. One point in the anatomy I want to emphasize is that lower lip tumor or embryological origin arise from the mandibular prominence, and it's right and left mandibular prominence are joined together in the middle, creating the mandible and the lower lip. While the upper lip has a right maxillary prominence, left maxillary prominence, and join the midline by the frontal process, and this is what we call it the fusion line of the face, if you remember. The reason why I asked, or I'm putting this here, is to tell you that there is nothing called the ipsilateral neck irradiation in lower lip tumor, but there may be ipsilateral neck irradiation in upper lip tumor if you need to. So you can consider a well lateralized tumor in the upper lip to be treated by ipsilateral neck radiotherapy if you need to. But for lower lip tumor, usually if you decided to go for neck radiotherapy, it will be bilateral, and this is an important point, and because they are embryologically, the upper lip and lower lip different embryologically, and it's important to be aware of that. For the treatment of the lip tumors is the same principle apply in all head and neck cancer. So for early stage head and neck cancer, we are talking about early stage mainly T1, T2, plus or minus N1 disease. And usually we ask the surgeon to take the tumor out. But after asking the surgeon of taking the tumor eye out, you will have the second question to come: what will be the functional outcome? So for early stage tumor, head and neck cancer in general, early stage, go for surgery, because we don't want to give radiotherapy after surgery. And then if the surgeons are happy and the functional outcome is okay, then patient should be sent for surgery. If the functional outcome is not okay, is not good, then it comes your way. And apply this for any site of the head and neck tumors. If you go for the larynx, for example, we talked about T1 larynx, and we said if the surgeon can take it out by laser excision, just go ahead. If not, then he should come to your side, because the functional outcome may not be as good. And so on. For T3, T4 disease, the majority of the patients who come to you will not reach T4 disease. And if this to happen, you have to ask what's going on, because a patient who have an advanced stage disease and seeing something in his face growing, and sometimes it's painful without taking action, I think this is something to think about. So the majority of the patient will come in early stage disease because they can see it in the mirror and they will come to you. Maximum will be T3 disease, rarely to be T4 disease. For T1, T2 disease, if the surgeon can take it out, well and good. If not, he's your patient, usually the commissure tumor. For T3 disease, usually is your patient. For T4 disease, if this to happen at all, we'll send the patient for surgery followed by adjuvant radiotherapy, because it is unlikely that you can control the disease properly with your radiotherapy, especially with advanced stage disease, can go to the mandible and cause mandibular erosion. For T3, T4 disease, usually we think about elective nodal irradiation, although some would say, I will treat the local disease only and leave the neck for later. I don't know why this would be suggested with a high risk of lymph node spread. And I usually say that for T1 disease, lymph node spread is around maybe 2 to 3%. For T2 disease, it reaches up to 10%. For T3 disease, you may reach up to 30%. And for simplicity, sometimes I put it as 3%, 10%, 30%. So you can multiply 3 times 10 so that you don't forget the figures. T1, 3% or less. T2, 10% or more. And T3 disease, the risk of lymph node spread can be up to 30%. So I don't think that I would leave a patient with T3 disease without neck radiotherapy or T4 disease without neck radiotherapy, but I see, so I just have to tell you about it as well. You can leave it for salvage if you think it's difficult, although it shouldn't be difficult to treat the neck nodes in a patient with T3 disease. This is a very common exam photo where they will put for you a photo like this and still tell you what can you see. So you describe that it's a lower lip ulcer, a lesion in the lower lip, very close to the lip commissure, rising mainly in the vermilion and extending to the skin. And then you describe it, and this likely to be squam or likely to be inflammatory. You'll not jump to be cancer. You have to put this, what we thought about, we'll have to see the patient, we'll take full picture and do clinical examination, and then full history of smoking and sun exposure. This could be inflammatory, this could be neoplastic, likely to be squamous of the lower lip, and that's it. And then you go for next. We'll take the patient to the MDT, clearly. You will discuss the surgery versus radiotherapy, and then he will tell you now the patient will come to your side for radiotherapy because the surgeon is not happy to operate because of the functional outcome of the lip. And then you have to be prepared for the radiotherapy technique then. In the radiotherapy technique, there is 2 ways of doing things. Some are doing the markup in the treatment machine or inside the treatment machine, but I don't like that because it usually takes from the time on the machine. And others would do it in the mold room. So you have to have very good light, and you have to have 2 pens or 1 pen. It's fine. Don't forget alcohol swab. and I usually say, if you have a ruler or you are going to buy a ruler, buy a ruler where the edge of the ruler is 0. So the 0 scale start by the edge. It's very useful, by the way, in your markup. So if a ruler start by 0 at the edge without leaving a space, this would be the best ruler that you can use. I like it. And then you'll need glove. You'll need a camera, because we need to document where the lesion was and where did we treat. And you will have also this plastic transparent sheets, very flexible type of transparent sheets, because you have to do what we call it like marking for the lesion and the surface of the patient, so that you can put it back on the patient. But we'll come to this at a later point. Then put the patient comfortable and keep him sleeping in a comfortable position, and then start to examine. Put your gloves and take the consent of the patient of examining him. And I prefer to do very important point. Please don't forget. So far, how many times don't forget? Don't forget to palpate the neck of the patient before examining his primary tumor, because it happens several times that patient complete his treatment for skin cancer or for lip cancer, and then he come in a month or two with the lump. So it's likely that the lump was there but was missed because we didn't examine the patient properly. So please make it as a routine for skin patient or lip cancer patient. Examine the neck before going to put the markup, because majority or most of those patients, we don't get a diagnostic scans for them. So if the lip cancer, we don't usually do diagnostic scan. For skin cancer, small skin cancer as well, we don't usually get diagnostic scan. So it's easily missed neck nodes. Then you will palpate the lesion and ask the patient that you will do that, and let him know. He should let you know if it's painful at all. And you will measure the thickness of the lid lesion, and you will look carefully on the extent of the disease, and then you start to draw your lesion using your markup. And I usually say, you can draw, and if any skin changes, take it, please. So don't be shy of taking any skin changes. If you think that there is some skin changes around the lesion, take it. This is your GTV. So I usually draw the GTV first, like that. And after drawing the GTV, I will put the lead shield inside. And this question will come specifically to ask about the lead shield inside the lip. And that's why we have to be very, very careful. Here we are, the lead shield. And the lead shield is, we'll put now the lead shield inside the lip. And the commonest question, as we all know, is that how much thickness you will use for the lead. And for electron beam, you divide your energy by 2 and then add 1 millimeter lead. That will be the thickness of the minimum thickness of the lead. So like if you have 9 MeV, so divided by 2 will be 4.5 plus 1 will be 5.5 millimeter. Please refer to the electron beam lecture. If it is a deep superficial X-ray energy like 120, maximum 150, few millimeter lead will be sufficient. And then the question will be, you will put a low Z number material, usually paraffin wax, around the lead, and he will ask you why. And it's very common that you have to, first he will ask you which direction. I mean, is it facing the lip or is it facing the teeth? And then he will ask you, the second question will be why. And we answer this question 100 times. The low Z material should be, we should put it facing the lip to avoid or reduce what we call it the backscatter. The backscatter radiation or radiation from interaction between the X-ray or the electron with the lead, and will go backward to hit the inner side of the lip and will be very painful to the patient. Inner side of the lip to the very painful to the patient. That's why the low Z material will be facing the lip. But I mean, the common practice is that you cover both sides of the lead with low Z material, because I wouldn't leave the patient in direct contact with the lead. It's toxic. So every day you will come and put a lead and in direct in touching the lining of the gingiva. I don't think this will be also safe to do. So you have to cover both sides. But the backscatter is meant to be to the back of the lead, facing, as you can see in the photo, facing outwards toward the lip, to avoid or reduce what we call it the backscatter. You have to support your patient, because this will be very painful for the patients. So after the treatment, when the treatment start to, like first week, second week, it will be very painful. So we have to give very strong painkiller. But before doing that, going to this, so when you put the lead, it will stretch your GTV. And here I can now put my CTV. So you can put the CTV after putting the lead inside, because it will stretch the lip. This is number one. And then you will have a photo, a camera photo for the final shape and position of the lesion. Usually we take for SCCs 1 centimeter margin. If you are using electron, you have to allow for what we call it, please refer to the lecture, the lateral constriction of the high dose isodose line in electron beam isodose line. So you take 1.5 or 2 centimeter margin around the lesion to allow for the lateral constriction, not the penumbra, right? We talked about it in the electron beam. It's to allow the lateral constriction of the high dose region. So if you are familiar with the electron, that's fine. Go with the electron from the start and don't say I will do this, do that. If you are familiar with the deep X-ray machines and superficial X-ray machines, then just do it. And it is ideal, honestly, superficial X-ray machine. So you take the margin, a small margin. The lead shield is small as well, so it will help. It will not stretch and be painful for the patient much. So it will be easy for the patient to put the lead inside the lip. And then you mark up. Before you take, and then you take the photo, and before the patient will leave, you will take the transparent sheet here. I think this, so now you will get the lead transparent sheet. So the transparent sheet, like the sheet of very thin and very malleable, and it will be like this on the patient. So it will be like, we'll put it on the face of the patient, and then we start to mark up the landmarks on the patient. So this will be like the mandible. We will draw it on the mandible, on the sheet, sorry, so that we know where was the mandible. Then this can be easily put again on the same position. I will draw the upper lip, for example. We'll draw the lower lip, for example, as well as the lesion, the CTV. We'll draw it on the transparent, and the GTV will draw it on the transparent. One of the radiographer was telling me just to put a strong markings on the lip, so that when he put the transparent sheet, it will come immediately like printed on the will be printed on the sheet. It will be easy for them to draw it carefully and make it more apparent. And every time, so after finishing the treatment, we will remove all the marks from the patient's skin using alcohol swab. Then the patient will return back. Then it will be easy to put the transparent sheet on his face, and we'll put where the CTV and the GTV, and also we have the radiograph, the photo that we took from the patient, and then we will treat just using the transparent marks without have to bring the doctor again to make the markup. Even after the disappearance of the lesion or the raw area sitting there, then we will know exactly where was the disease and where was the CTV where we have to treat. So this is a very important technique, or the technique, step-by-step technique that you have to be aware of, and you have to show the examiner that you're doing it every day. How to calculate the energy? It's very simple. It's usually 120, 150 maximum. You don't usually do more than that, especially for thin lesions like that. But when you go for the exam, you will tell them that I'm going to use the table. There is a specific table for each machine. So I'll use my tables. And after taking the measurement of the lead cutout, so the lead cutout is the area that will be exposed for the radiation. So the lead cutout, let's say, will be 4x4 or 5x5, so that you can use a cone of 5. And then you will go to the table for the energy. You will see the percentage depths of those, and you choose the energy, and you will choose how much energy you need to use to treat this patient based on how much depth is the lesion. Usually it's 120, 150 maximum for the majority of those patients, and this is an easy way of doing things. Then the backscatter, this is if you refer back to your physics book, you will see this. So it's a very famous question, and now we are all aware of that. If this is the lip here, so the backscatter will be on the inner side of the lip. That's why we are putting the low Z material in front of the lead to absorb the backscatter factor. And this is a very common question in the exam, even in the MCQ as well. They will talk about what does it mean, the backscatter factor, and sometimes what to do in lip cancer radiotherapy and so on. Supporting your patient is very important. So when you start the patient on treatment, please don't forget that he will need strong painkillers. So I usually give the patient morphine and tell them, please, when you come for your treatment, you will need the morphine. So take it 15-20 minutes before coming for your treatment. And then also you can use oral mucosal lidocaine gel, which will help as well to put the patient the lead shield inside. I usually keep the lead shield with the patient, or I will ask the patient to put it himself. So I don't ask the radiographer to put it, because it's much easier for the patient to put it himself or herself, and it will be less painful when they push it. They know exactly how to push it and put it the same position, so that will not be painful. If you have intrasite gel, you can use intrasite gel. You can use also morphine with intrasite gel to reduce the pain, but if you don't have it, then lidocaine. If you're using lidocaine spray, it will sting and be painful initially before it goes numb of the lip. So please tell the patient that the lidocaine will sting and be painful before you put it inside. For advanced stage disease, T3, T4 disease, we need to treat the neck. And here is the photo from Dr. Mendenhall head and neck textbook. It's a very nice textbook, by the way. I'm not sure if there is a new version or not, but most of if you search for any answer, you can find it on this book. Any technique, you can find it in this book. So it's a very, very useful. And I like this idea actually, by using the tongue elevator or mouth bite. This is a cork, but I'm not sure if we will use it in daily practice. So what I'm using is a tongue depressor, but I will call it now elevator, and we put wax on it so that the patient can bite it and indent the surface of the wax, so that you know exactly how much is in and how much is out. And you know also that and then they will be able to put every day the tongue elevator on the same position. The tongue will be pushed up, not down. This is very important because it keeps the tongue surface away. And also to keep the upper lip away, and then you use two parallel opposing, including the neck nodes, and this can be easily matched with a half beam block, lower neck field, anterior neck field, as usual as any two parallel opposing and one anterior neck. And you can also add midline shield for the anterior neck, lower anterior neck field, and that's it. So this is a very nice technique, and I'm using it for many years now, and I did also some modification on it if you would like to have a look at it. So if I'm using a VMAT, this is one of my patients with T3 disease. I'm treating the neck at the same time. So what I'm doing here is I'm putting a mouth bite where the tongue is pushed away, and then I'm putting bolus on the surface as usual, but I'm putting also bolus inside the lip. So the reason why I am using this technique is to push the lip away from the mandible as much as I can, if this allow me. And sometimes even I use a piece of foam, so small piece of foam, in addition to the wax, if the patient will allow me to do that, and then this will push the lip away and the bolus on the surface. So you end up by having the high dose region away from the mandible, as you can see in this photo here. And then the neck node will take the usual dose, 54 gray if negative. If positive, then you increase the dose. But using these techniques for a long time now, I can easily tell that the main problem will be on the lip, and the patient usually do not need a feeding tube for feeding and eating and drinking properly. So he can push. Whenever he opens his mouth, just push the fluid and push the liquid away. Some they use like chalumeau, what do you call it, like to help drinking and taking some supplements orally as well. But it's very useful, and keeping the tongue away usually make the treatment very, very tolerable. Anyway, this is a technique that I'm using. I'm hoping that you will find it useful. And let's continuing with the oral cavity tumor next lecture, inshallah. Thank you.